Good evening, everyone. I'm just waiting for the audio and video. Before starting, once we get a go ahead, we begin. So we are good to go. So we'll start. So welcome everyone to my session. Myself, Dr. Rijul Agarwal. I'm the Orthodontic faculty at NAMS. So we are, if you can say, 2 weeks, roughly more than 2 weeks before your NEET exam. So in prospect of that, I've kept a MCQ based discussion today on the subject of orthodontics. I hope to have a maximum participation from your side. You can post your answers in the comment section to make the session more interactive, and I'll be able to help you out as well. Okay, with your queries as well. Okay, so we'll start. So once again, good evening. So beginning with the first question. So in assessment of skeletal age based on cervical vertebra seen in lateral cephalometric radiograph, stage 3 indicates. So this question is related to CVMI staging, cervical vertebra maturity indicator. Okay, and it's asking you directly about stage 3. So the options are more than 1 year beyond peak growth, no growth, less than 1 year prior to peak growth, and last option is peak growth still a year or so ahead. So what will be the answer? Okay. 2 to 3 points left to CVMI. CVMI was given by Franchi and Bessetti. Name of the scientist was important. Other parameters which can be asked related to, they can give you an image based question from this as well, or you can get a full case based scenario as well. Okay, full case based scenario in which they will give you a patient child reported to your clinic with the following so and so stage. What kind of option, what kind of appliance will you get? Okay, so we have one student who is saying option A. Anyone else? It's a very simple direct based question. Okay, related to CVMI staging. Okay, another one says option A. Okay, so I'll move towards the solution then. Students, I'll again ask whosoever is online, don't hesitate to write your answers even if it's wrong. Okay, that's way you will know your preparation. Okay, and where you stand. It's a certain kind of self-assessment kind of a discussion. I am not testing anyone, so a disclaimer, I think I gave it in the last session as well. In my MCQ based discussions, you will find certain questions with more than 4 options as well, and more than 1 answer correct as well. Okay, so I have formed the questions based on to make you guys understand and not to test anyone. Okay, so in NEET or in INI, they can vary in the options and all that. My idea is to revise and give you a broader aspect of the type of questions which you can face in the exam. Okay, so the correct answer is option C. not option A, that more than 1 year beyond. Option A is beyond the peak growth. Stage 3 is indicated that less than 1 year is prior to the peak growth is indicated. Okay, so this is correspond to stage 3. Peak growth is at stage 4. Stage 5 is option A. Okay, and option D is roughly indicator of stage 2, that peak growth still a year or so ahead. Okay, so a brief discussion given by, as I told, Bassetti and Franchi. So earlier there was CVMI stage 6, later it was modified to combine 6 stages into 5, that is, and the name was also changed from CMI to CS, that is cervical stage 1, 2, 3, 4, 5. Okay, what were the two vertebrae which were used? C2, C3 and C4. C1 is non-visible, you know from your anatomical classes. Okay, so one is will occur 2 years after this stage, with 2 is average within 1 year or more, 3 still within the 1 year or after this stage, 4 has already occurred or is still in the peak mandibular grades, and 5 the growth has ended, and 6 at least 2 years before this stage. You know, important is to also know the shape of the lower border, which will help you in the image based questions. Okay, so moving ahead. Next question. Again, a growth modification procedures are best carried out in which stage of Singer's method? Again, a skeletal maturity indicator based type question, stage 1, 2, 3 and 4. So what will be the answer? So they are now asking about according to Singer's method. Okay, someone said B, stage 2. Okay, another B. Okay, so I'll give you the correct answer is B. Okay, so B corresponds to the stage 2, that is the pre-pubertal stage. Okay, so stage 1 is early, stage 2 is pre-pubertal, 3 is pubertal onset, the puberty is already occurred, stage 4 is pubertal, stage 5 pubertal de-extension, and stage 6 is growth completion. Okay, so the best time to intervene with a growth modification appliance is stage 2. Next, which of the following cephalometric parameter is used to diagnose a patient with long face syndrome patient? Options are A and B angle, SNA angle, Zaravec ratio and saddle angle. Okay, so we have a lot many options which of the cephalometric parameter is used to diagnose a patient with long face. So the question is asking what long face means. In vertical, the question is vertical dysplasia indicator. The correct answer is Zarabak ratio, option C. A and B angle is related to anteroposterior or sagittal dysplasia. Okay, SNA angle is a part of A and B angle only, and saddle angle refers to the, first of all, what is the saddle angle? It is between nasion, sella and articulate. So it refers to the cranial base flexion, or you can say cranial base से क्या attach होता है? The bone which is attached is the mandibular bone which is attached. So it reflects to the position of the mandible, whether it's backwardly position or forwardly position based on that. The correct answer is option C, that is Zarabak ratio. Yes, and what is the formula to calculate? It's the ratio of posterior facial height to anterior facial height into 100, and the value numerical data less than 62% expresses a vertical growth pattern, whereas more than 65% expresses a horizontal growth pattern. Please note the posterior comes in the numerator and the anterior comes in the denominator. So it's a percentage based ratio. Next question. Peck and peck index. The mesiodistal and buccolingual measurements of which of the following tooth is taken? The maxillary central incisor, mandibular central incisor, maxillary premolars or mandibular molars. A very easy question, just asking you about the which tooth it is does it take. Out of the following? So most of you, or I can say everyone has got it right. It's mandibular central incisor. So which two teeth, if you can say, so it's the mandibular LI and central incisor. Why it's taken? It indicates the increase in the mesiodistal, or how much stripping, proximal stripping can be done. So it's the index of mesiodistal crown diameter divided by the faciolingual crown diameter into 100. So for central incisor it should be 88.4 plus minus 4.3, and for mandibular lateral it is 90.4 plus minus 4.3. So again a very easy question, direct question. Okay, significance should be known. See, in model analysis from orthodontics, you just need to know the ratios, the numerical values and its significance. That's all. No one is going to ask you in the exam to calculate the discrepancy or something like that. What will be the significance, or what case and what needs to be done. If you know that, that's all. Next question. So according to American Board of Orthodontics, recommendations for color coding of sequential tracing and treatment stem tracing is. So what is the color coding? Black, blue, red or green? So it's asking what end treatment stem tracing. So yeah, A, C, C. Now we have question 88.4. How to calculate? I'll just get back to it. Okay, I'll tell you that first. Okay, so the index ratio is calculated by calculating the mesiodistal crown diameter with a vernier caliper, and it's done inside the patient's mouth. No need to obtain a cast. Divided by the buccolingual crown diameter into 100. That's how it's calculated. Okay, so whatever the index value comes, okay, whatever the value calculated value comes, it's compared with the value which is given by Peck and Peck. If it's more, you can strip or reduce the diameter. If it's less, you cannot do any more proximal stripping process. Okay, so this is the significance and this is how it's done. This 88.4 value, 90.4 value are the standard values given by Peck, Sheldon Peck and Peck. Okay, I hope I'm clear. Now some are saying black, some are saying red. So it's asking about end treatment. Okay, black is for pre-treatment, blue mid-treatment, red post or end treatment, green is for retention. Okay, so this is the answer, hence the answer is answer C, option C, that is red. Plus 4.3 this is the significance if you have done in public health. Okay, plus minus 4.3 is acceptable, the average value is acceptable. Okay, so every time we get an average and plus minus, if you remember that bell shape, plus minus from that value. Okay, so based on the standard values calculated them by them, they did a study based on a top series of study rate from various population, and based on that they arrived at this value. Okay, so this is the standard color coding sequence given by American Board of Orthodontics for various cephalometric radiographs. Okay, moving ahead. A big thoda lengthy question. All of the following are advantages of indirect method of bonding brackets to a tooth over the direct method except one. Which one is the exception? Okay, so thoda sa question ko bada kiya, they have just twisted it and they are asking you which one is the incorrect statement or false statement regarding indirect method of bonding. Okay, option A, reduced chair side time, more precise location of bracket position in the laboratory, control thickness of resin between the tooth and bracket interface, less technique sensitive, easier cleanup during bonding and debonding, and better visualization in lab. So what will be the incorrect or false statement regarding indirect method of bonding? So one is the direct method, which we do it directly on the patient, and next is the indirect method. Questions like these, जब भी they come on your screen, they are just made to confuse you or create panic. इतना बड़ा क्वेश्चन है, क्या होगा इसमें, तो इतने ऑप्शन है, 1 मिनट तो उसको पढ़ने में ही लग जाएगा. But when you read this question with a calm mind, it's a very easy question that even a person who doesn't know the subject of orthodontics can answer this question very easy. So again, I'll ask, right now there is no hurry, there is no exam. Read the question with a calm and cool mind and then you can answer very easily. Statement को घुमाने के लिए उन्होंने बड़ी सी फर्स्ट लाइन दिया, लेकिन all of the following are advantages of this over the direct method except one. Which one is the exception? Just the examiner ने इतना बड़ा statement बना के they are just directly asking you which one is the incorrect statement or which one is not related to, which one is the exception of indirect method of bonding. Like in prosthodontics, sir would have taught you about casting, direct casting and indirect casting method. Similar kind of thing. What is Eastman correction? Okay, I'll tell you that later on. Eastman correction. If I forget at the end of the session, just post it on the group. I'll answer that. Eastman correction. Right now, just focus on this question. Someone said D. We have B, C, D. Okay. So just to give you a brief overview, what is indirect and direct? Direct method is the one in which we bond the bracket directly inside the patient's mouth. Okay, we take the patient bracket, open the mouth, put the etchant, bonding agent, composite, place that. In indirect method, what we do is we take the cast or impression of the patient. Okay, we take it to the lab, bond the brackets on the cast, then obtain a tray or a template of that and take that template inside the patient's mouth and directly place it and cure it. Okay, so what will happen when we do this? In direct method, the patient's mouth is open for a long time. Okay, it is an increased or a lengthy procedure. We have to place one bracket. In indirect method, just a cast is taken, and in the next appointment, the template is placed and quickly the bonding is done. So reduced chairside time? No. So it is the advantage, not a disadvantage, hence it's eliminated. Next, more precise location of bracket position in the lab. Of course, you have a cast, you can hold it in hand, visualize in 3-dimensionally. You cannot do that with the patient's mouth. So it's also a correct statement and it's eliminated. Control thickness of raising between the tooth and bracket width. Definitely. Inside a lab, you can do everything. You can control the thickness. Even if you place it incorrectly, you can remove the bracket, place it correctly, remove excess flash and all that. Less technique sensitive. Technically, it's more technique sensitive. Why? Because you need to have a cast inside, you have a proper template banana, uske liye you need to have proper equipment for that and all that. So it's more easier cleanup during bonding and debonding. Again, a true statement. Why? Because the flash is reduced, the composite material is reduced, you can clean up and it becomes more easy. Better visualization in lab, definitely. Hence, D is the correct or the false statement. So it's more complex and technique sensitive. So this is a procedure which I told you just now. The cast is obtained, the lines are drawn, and with that the brackets are placed. Okay, then a template is made using a silicone tray and the brackets get embedded inside that template. That template is directly taken inside the patient's mouth. Before that, etching is done of the whole, all the teeth on which brackets supposedly 6 to 6 or from 7 to 7. Okay, that template is placed with the resin on the bracket and then directly cured. And the template is taken out, the brackets get stick to the patient's teeth. Next, the Hawley's retainer is the most common retainer used in the orthodontics because it uses palate for anchorage. So, true and false type of question, which statement is correct or incorrect? Both statements are reasons are correct and related. Both statements and reasons are correct and not related. So it's a combination of that. True and false as well, and an assertion reasoning type of question. Statement is correct, reason is not. Statement is incorrect, reason is correct. Both are incorrect. Students say A. Anyone else? Okay, so the statement the hollow retainer is the most common retainer used, not a very, it's a correct statement. It uses palate for anchorage. Another statement, this is also correct. But the reason that it uses palate for anchorage and it becoming most commonly used are not related to each other. These statements both are correct, but the reason for offered for it to become more popular or most commonly used is that because it uses palate. Rather, if for it using being the palate creates discomfort for the patient, so its popularity should have decreased, because imagine full palate covered by acrylic, it becomes very difficult for the patient to use it, and that's why the reason for the evolution of SX retainer and fixed retainer. Okay, hence their reasons are correct but are not related. Okay, the most common reason of why it's used is because a number of modifications can be done with it. Okay, you can modify the labial bow, make it active as well. Okay, split the labial bow, a number of corrections can be carried out with it. Okay, so yes, the B is the correct, that both are correct statements but are not related to each other. Okay, next question, which condition should be treated at an early age? Deviated midline in absence of functional shift, mild crowding of lower permanent incisors, two deciduous molars nearly in crossbite, posterior crossbite with functional shift. So which should be treated at an earlier age? Or you can say early age, or as soon as seen or possible, whenever you see it, this thing should be corrected. C, D, 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 Okay, so most of you are with option D, hence it's the correct, that posterior crossbite with functional shift. Okay, A option, deviated midline in absence of functional shift. So what is functional shift? Functional shift occurs that when the patient closes his or her mouth, the mandible or the jaw deviates. So opening the midline coincide, closing it deviates. That means there is some occlusal prematurity due to which the patient is shifting the jaw while closing. That is a functional shift. So that the functional shift, if and when observed, should be corrected as soon as possible. Why? Because if it's not corrected, it can lead to a skeletal problem. Now the option A says there is absence of functional shift. There is deviation in the midline in the absence of functional shift. So you can correct it later on as well. There is no need to intervene at an early age. Mild crowding of lower permanent incisors definitely can be intervened. Why? Because of late mandibular growth, the crowding can increase as well. So it can intervene at a later stage as well. Two deciduous molars nearly in crossbite. Now they are saying nearly in crossbite, means they are in H2H bite, and that's also deciduous molars. So the premolars erupting can also erupt in the correct position as well. Last, posterior crossbite with functional shift, the most problematic thing. If there is a functional shift, you have to immediately address it and correct it. Next question. Which of the following are not a symptom of sucking habit? Again, as I said, multiple options can be correct or even one can be correct as well here. Anterior open bite, crossbite, expanded maxillary arch, proclination of incisors, retroclination of mandibular incisors, or class 2 malocclusion. So which of the following is or are not a symptom of sucking habit? C. Someone said B and C as well, both. Okay, so most of you are agreeing with C is not a symptom. Okay, anterior open bite. Definitely, if patient has a thumb sucking habit, it can lead to anterior open bite because of the presence of thumb. So it's a symptom. Crossbite. Now they are not mentioning the crossbite is there in the anterior or posterior region. So the crossbite, yes, can occur in the posterior region, hence it's a symptom. Yes, someone said crossbite posterior can occur, so it's a symptom of thumb sucking habit. Expanded maxillary arch, no. Constricted maxillary arch, not expanded. Proclination of maxillary incisors, definitely. Retroclination, definitely, because of the presence of the base of the thumb. And class 2 malocclusion, definitely. Why? Because of the downward and backward rotation of the mandible leading to detruded mandibular. So the only option here is option C, which is incorrect or not a symptom of sucking habit. Next, a poor man's cephalometric analysis is performed via dental cast, facial profile, photographic analysis, or full face analysis. C. Photographic analysis, full face analysis. B. So now I'll move ahead. The answer is B, that is facial profile analysis. So what is cephalometric analysis? Normal cephalogram, it's a lateral cephalogram or the profile of a patient viewed on a skull. So poor man's cephalometric analysis is a term given where you don't do take a proper x-ray, you just analyze the facial profile of the patient by looking at the patient and give your diagnosis. So the term which was given is facial profile analysis or poor man's cephalometric analysis. Okay, so it will just give you the following information, that is the endoposterior position of the jaws, the lip posture, the vertical facial proportion, and the inclination of the mandibular plane. Next, which of the following does not correlate with steep mandibular plane? Long anterior vertical facial dimension, anterior open bite, tendency towards class 3, and greater mandibular plane angle. Again, does not correlate. These are the common words which they use instead of asking which of the following is the incorrect statement. Does not correlate, not related to, all except. These are the common terms. D. Greater mandibular plane angle. B. Anterior open bite. B. Now, steep mandibular plane angle. If we imagine this is the maxilla, this is the mandible. Now the angle is steep. This angle is steep. So what will happen? अगर ये angle ज़्यादा steep है, so it will lead to increase in the anterior vertical facial dimension. Similarly, the teeth present will also get open, so there will be open bite present in the anterior as well. Similarly, this angle is open, so the mandibular plane angle will be also increased. Now, since the mandible rotates downward and backward, so related to the maxilla, the mandible will be posteriorly located. So it will lead to sort of class 2 skeletal profile or class 2 skeletal conformation. So does not correlate means tendency towards class 3 won't be there. Rather, it will be tendency towards skeletal class 2. Hence, the does not correlate or not related to with steep mandibular plane. Sorry for the temporary delay. I hope I am clear with this question. Okay, so steep mandibular plane angle. Okay. Moving ahead, once bone is formed, it grows by So the bone formation is complete. It's related to the growth topic, growth and development, interstitial growth, appositional growth, both appositional and interstitial growth, and degenerative changes into the bony structure. Okay, now please remember the topic growth and development is the most boring and neglected topic according to me in orthodontics. But this makes the base, and in last I think INI exam of November only, lot many questions came from this topic. So please don't ignore it. Okay, now we have, sir, what is seen in the outermost circle of Ackermann profile? Intra-arch alignment or profile? Sir, explain. Dr. Ria, if you have any other question, just kindly tag me in the group. I'll definitely answer it. Okay. Right now, I want to phone because I want to show you a new image as well of certain appliance. So I won't be able to answer it right now. If you have any other question related to any other topic, just write in the group or in the WhatsApp group or the Facebook group, and definitely answer it. Okay. Now we have a student here. Explain last question again, please. So this is the maxilla, this is the mandible, and the question says steep mandible. So the mandibular is downward or backward. So this mandibular plane is steep, so this angle is increased. Okay, so what will happen? Once this angle is increased, the mandible has rotated downward and backward. What will happen? The teeth attached to it also get down. So there will be anterior open bite, okay, and long anterior for vertical dimension will be there. Okay, hence eliminated it. And since the mandible has rotated downward and backward, the mandible is relatively posterior in position, so there will be skeletal class 2 present. So tendency towards class 3 won't be there in patient with steep mandibular plane because of the downward and backward rotation because of the steep mandibular plane. Hence the incorrect statement, or does not correlate with the steep. Now coming to this question, we have students who have said CP, interstitial growth, oppositional growth. Now this is the bone which is completely calcified. Okay, the correct answer is appositional growth only. Okay, no interstitial growth will be occurring because the surface is calcified, so nutrients cannot be supplied from below, from the center. So appositional deposition, or you can say what is appositional, surface deposition, will only occur for the bone to increase in its length or size. Interstitial growth does not occur. Both occurs in cartilage. This is completely formed or calcified bone. Okay, so hence appositional growth only. Next, easy question. Primary molar relationships are also known as or also class relationship, step relationship, primitive or occlusion relationships. So we have B, I won't wait much for this question. The correct answer is it's a step relationship. Mesial step, distal step, flush terminal, the step formed by the posterior margin or the distal margin of the primary decutus molar or the ease. Again, which of the following is or are false regarding mixed dentition analysis? Again, multiple answers can also be correct or incorrect as well in it. The question is asking about the false statement. Used to predict the amount of crowding after permanent teeth. Here, determines the space available versus space required. Option C, analysis is based on correlation of tooth size. Option D, performed during mixed dentition. Option E, generally performed using a Bowley's gauge study model and prediction tables. Option F, analysis is done for each quadrant. Most common is among mesial and flush terminal. Most common is mesial step. Okay, so moving ahead to this question. False regarding mixed dentition analysis. Predict the amount of crowding after permanent teeth erupt. Determine space available versus space required. Based on correlation of tooth size. Performed during mixed dentition. Of course, it's performed during mixed dentition only, so hence this option is eliminated. So we have someone says A. Anyone else? Multiple options can also be correct in this question as well. In need, you will get one option correct at question only, so they'll just provide you option A as 1 and 2, 2 and 3, only 3 and 4 or likewise. By various permutation and combination, they can give you an option. F, A, Okay, so we'll proceed towards the discussion. Okay, used to predict the amount of crowding after permanent teeth erupt. So the basic premise of doing mixed dentition analysis is to estimating the width of the erupted permanent primary canines and molars, and used to determine whether there is enough space available for the permanent canine 3, 4, 5 to get erupted or not. So the amount of crowding after permanent teeth erupt, if there will be crowding or will be spacing, can be determined using mixed dentition. Okay, so the basic premise of doing mixed dentition analysis is just to determine whether will be crowding or there will be spacing. If there is going to be crowding, whether any intervention can be done at this stage so that future crowding or future orthodontic treatment can be shortened or not. Hence, it's a true statement. Determine space available versus space required. I've just explained. Analysis is based on correlation of tooth size. Definitely, you correlate or determine the tooth size of the primary can CDE and correlate it with the permanent 3, 4, 5. Performed during mixed dentition, definitely. Generally performed using a gauge, study models and prediction tables, various analysis using different methods to determine. Hence, the only option remaining is F, which is a false. That is done for each quadrant. It is not done for each quadrant. Sometimes it is done for lower quadrant, sometimes it is done for upper, and based on the correlation, various other prediction tables and various other some authors have used different methods. So it's not done for each quadrant. Okay, hence the false statement. Next question. So we'll need to hurry a little bit. I have only allocated 1 hour for this. Patients with crowding or 4 mm in primary dentition, least effective method of treatment is wait and watch, stripping, extraction, all are effective. So there is crowding of 4 mm, you have determined it. In the primary dentition, what needs to be done at this stage? Okay, so no, they are asking about the least effective. Wait and watch, proximal stripping, extraction, or you can say the option is all are effective methods. There is none of them which are least effective. Now we have A, wait and watch, A, so most of you are saying A with this. Now students, I want to highlight to you here is the big thing which they have mentioned in the question is primary dentition, and next is least effective. A primary dentition, deciduous dentition में why will you go with extraction of teeth? So hence this becomes the least effective method of treatment. प्राइमरी डेंटिशन में 4 mm की क्राउडिंग है. CL extraction is also done when the discrepancy is approximately 9 to 10 mm, and that too at a time when permanent incisors and molars have erupted. Why will you go with the intervention? So what's the problem with wait and watch? At this stage in primary dentition, I agree, the dentition should have space. Even if there is space, the joint, primary dentition, what will you do with intervention? So the wait and watch is the most effective. Next you can do proximal stripping, okay, but least is extraction. Which teeth will you extract? What will you do to correct that crowding at primary dentition, and what will it gain you? कि आपने प्राइमरी डेंटिशन में क्राउडिंग करेक्ट कर दी तो परमानेंट में नहीं होगी, इसका क्या गारंटी है? हमारी ऑर्थोडोंटिक बायोमैकेनिक्स एक्सट्रैक्शन पैटर्न इज मोस्टली लिमिटेड टू परमानेंट. हाँ, यहाँ एक्सपेंशन का कोई ऑप्शन होता आई वुड हैव, बट हियर दे आस्किंग अबाउट लीस्ट इफेक्टिव. लीस्ट इज एक्सट्रैक्शन. मोस्ट इफेक्टिव आउट ऑफ दिस इज वेट एंड वॉच. हाँ, अगर एक्सपेंशन का होता तो दैट वुड हैव बीन मोस्ट इफेक्टिव आउट ऑफ दैट. So I hope I am clear. Extraction of teeth is the least effective method at this stage in primary dentition. Okay, so please question को काम होके ध्यान से पढ़ना. They are asking about primary dentition or permanent dentition and least effective. Again, which is not a symptom of OSA, obstructive sleep apnea. Watery mouth, maxillomandibular differential, morning headaches, daytime sleepiness. Sir, it mentioned more than 9 to 10 mm crowding, then A would have been correct. Yes, even if 9 to 10 mm crowding is there, Komal, but they are writing about primary dentition. Okay, I'll come again, go back to the previous question, just like she's asking, 9 to 10 mm crowding is there and the dentition is primary. The child is of 4 to 5 years of age. What will you do with intervening with proximal stripping and extraction of teeth? Which teeth will you extract? What will you do? What will you gain? Then also you will have to go with wait and watch. Would be the most effective, and least would be at that time also extraction. So again I'm saying they are asking about least effective, means ये method you won't use, you cannot use. Just question को twist and turn करके language घुमा के they are asking. तो basic premise या basic crux of this thing is primary dentation जिसमें permanent teeth कोई भी नहीं आया है, crowding 10, 20, 25 mm, 25 mm, how much so ever crowding is there. You can only, what you can do is wait and watch at that time, and you cannot intervene with anything except you can go with expansion. Now you have various appliances like myobrace as well, which just stimulates or expands the jaw so that the jaw development occurs. इतनी severe crowding इतने young age पे हो रही है, इसका मतलब jaw constriction है और there is some problem. Dentition में इतनी severe crowding आती है, नॉर्मल जॉ डेवलपमेंट में इतनी सीवियर क्राउडिंग होना पॉसिबल नहीं है. So at that stage the most effective way would be, it's such severe crowding even 9 to, you can just expand the jaw. Expansion is the way. Okay, so coming to the next, which of the following is not a symptom of obstructive sleep apnea? Watery mouth, maxillomandibular differential, morning headaches and daytime sleepiness. Let's say A, C. Headaches, daytime sleepiness would be there of obstructive sleep apnea. Now I have to rush it a little bit. Now, what is obstructive sleep apnea? The mandible can be retropositioned or can be obstructing the airway. So there is definitely a differential between the present. Differential means the length difference between the maxilla and the mandible. So watery mouth is not a symptom of obstructive sleep. Hence option A. Identify the appliance: pendulum, pendex, T-rex, Hilger's appliance. Okay, exam में ऐसा से ही एक zoomed out image, I have deliberately put up such kind of image जो दूर से बिल्कुल दिखे ही ना, zoom in करने का भी कोई option नहीं है, because I know after seeing this image many will say कि sir zoom in. Okay, in exam in your computer screen ये ऐसे kind of images देते हैं हम जो बिल्कुल दूर दिखे, and based on that only you have to answer. So this is such kind of practice for you. I don't think so you will have a provision for zooming in. Okay, so most of you are saying that it's a T-rex appliance, hence it's the correct answer. Which of the following is true for Frankel type 5? Frankel type 5, we have 1, 2, 3, 4, 5. Used in vertical growers, used in horizontal, used in patients who need headcare, used in patient with class 3. It's again a PYQ. Okay, so I cannot be able to wait for it. It's used in vertical growers, not used in horizontal growers, used in patient who need headgear, used in patient with class 3. So in class 3 you have frankel type 3, horizontal we have type 2, headgear type 5 and vertical type 5. Hence 1 and 3 are correct, option C. Which of the following is not true about quad helix? So quad helix appliance helps in molar re-rotation, anterior expansion, posterior expansion made up of 1.3 inch SS. So not true is made up of 1.3, it's made of brackets 0.38 inch wide and the force applied is 200 to 600 grams. Again, a long question, true about obstructive sleep apnea is. So it's a question based on AHI index. The correct answer is option A. That combined number of apneas that occur per hour of sleep. They are asking out per minute, that occur per night, per week. No, no, no. It's per hour of sleep. So again, a definition based question. Okay, as I mentioned, definition based question में need to read it thoroughly. जो definition है, जो concept है, you need to understand. Okay, and one more thing, the classification of AHI index. Okay, and in the last there is a appliance which I need to tell you about, that is the EVA appliance. It's an experimental fixed appliance activator. Okay, so it was given by Van der Schuren and D. Smith in the year 94. Consists of a solid block of acrylic with protruding wires that are inserted into tubes of upper molar pans. Okay, it can combine fixed orthodontic treatment with skeletal correction, so it becomes ideal like the fixed functional appliance to be used at the end stage of growth. Okay, so at the same time you can address the skeletal correction and align the teeth as well. So this is the image of the appliance. So like the activator, it consists of a monoblock appliance. You just need to buy it. There is a wire protruding which can get inserted inside the molar tube, and same time fixed orthodontic therapy can be carried out like that. Okay, so with this I'll end the session. Okay, if I have missed out any doubts, you can write me on the WhatsApp group, Facebook group, Facebook Messenger. I am myself Dr. Rijul Agarwal. If any students are not there in the WhatsApp group, you can message me on the Facebook as well. I'll be very happy to answer any doubt if there is. Okay, so with this I'll close the session. Thank you for joining. So we'll meet again in April with a revision or a predictor series, the schedule of which is being finalized. Okay, before your NEET exam. If anyone wants anything from the field subject of orthodontics, कोई topic or some discussion, just message me. If it's possible, we'll definitely take it. Okay, thank you for your time. I just said.